Welcome, Gyno-Curious listeners. I am Dr. Amy Novat. We are here to investigate what it means to be a healer and to be healed. When I think about who I might invite as a guest on Gyno-Curious, I like to think about medical experiences, diagnoses, or concerns that affect many women, not just a few. Today's topic, obesity, or being overweight, is unfortunately a concern that affects far too many women in this country. We now have an American population that is heavier than ever before, and combined with chronic diseases like heart disease, diabetes, and cancers, make them particularly unwell. I have been lucky to be graced with good genes for a healthy weight. I also like to exercise and am privileged to eat whole and local foods, but many women across this country don't have these traits or capacities. I have invited Dr. Brian Bonetti to discuss his experience with bariatric healthcare. He explores the many aspects of weight and the newer science that is helping us better understand that obesity is not simply a result of overeating. Dr. Bonetti is a board-certified and fellowship-trained minimally invasive and bariatric surgeon. He is the director of metabolic and bariatric surgery at Northern Dutchess Hospital. Brian, welcome, and thanks so much for joining me today.
Yeah, thanks for having me.
Brian, like me, every day women come to your center to discuss their weight. How often do they arrive at your office driven more by shame and the pursuit of thinness rather than a true problem with weight?
I think for me, I see patients mainly based on weight as a disease process and a disease burden. Rarely are patients coming to me, I think, based on shame. A lot of times it's trying to get back a piece of their life that they feel like they've lost. They can't do the things they want to do anymore because their body hurts. They are in pain. Their back hurts, their knees hurt, their hips hurt. They don't have the energy to do the things they want to do. Their kids are still young and they want to be able to keep up with their kids. And they are fearful that because of their obesity, they're going to develop disease processes that are maybe going to end their life too early, and they want to be there for their kids. For me, I guess I don't see the shame part a lot. It's more the disease part.
Right. We're talking about biology and lack of health as opposed to the moral standards or social standards.
Yeah, I think so.
Yeah. So we're in another kind of pandemic other than COVID. According to some recent data, in North America, 73.9% of people are considered overweight. Or another way of looking at it is more than 2/3 are deemed overweight or obese. Can you help our listeners understand what does overweight and obese mean?
Those definitions are based on what's called body mass index. So body mass index is a ratio of our weight to our height. So it's a calculation, really. It's not the most perfect calculation there is, but people then get characterized based on that number. A range of 18 to 24 would be normal, and 25 to 30 would be considered overweight. And as soon as you start to get 30 or above, you start to get into obesity in class 1, class 2, class 3. I think that's a somewhat, I don't know if it's an arbitrary number, but it is a number that is guiding that definition. It's interesting if you look at population studies, meaning take a large group of people and look at them based on their weight and how long they live. Patients people in the overweight category actually live longer than the normal weight category.
All right, you got to explain that one to me. What do you mean?
People think that the reason that is because the normal weight category really allows for very minimal body fat. And having some body fat is important in case you get sick and you have fuel to burn to get through that hard time. So that's one of the thoughts of why an overweight person will live longer than a normal weight person.
That's great. It's what it allows for in our vast array of body types is a place for people to find health and comfort in having a little plumpness, and that this thinness that we are currently looking at in our magazines and advertisements isn't necessarily the healthiest way to go.
Yeah. I think it's okay to have a little, or to technically be classified as overweight by this number, but know that you're in a healthy place with your physiology, so to speak, that you actually may benefit from that. So.
Yeah, I certainly hear criticisms about ideal body weight vis-a-vis there are athletes, for example, who are considered above the ideal body weight, and yet they're strong, fit, and expert at what they do.
Yeah, totally.
Yeah. So sometimes it's really hard for me to disentangle my own self criticism, body shaming, and focus on thinness from how I see my patients. You're a fit, healthy, weighted man. Do you ever have trouble keeping your own expectations around your own body into the filtration or how it filters into how you counsel and your attitudes towards obesity?
I don't think so. I think what I've learned about obesity is it's such a complex disease. And the concept that someone is in control over the weight is almost, I'm starting to understand that people really don't have control over their weight. This concept that your brain kind of sets your weight for you like a thermostat, and that you're beholden to this thermostat. And this thermostat that you have has an auto feature and keeps you in that place. So I'm sure you've experienced it. You gain a little weight, you lose a little weight, but you hover around the same area generally. It's very common for my patients to have that experience where they are, "Oh, okay, I'm going to go on a diet, I'm going to do everything right." And they don't really see much weight loss, or maybe they lose 10 pounds and then they kind of stall out at that point. There's so much to it that we're starting to learn that, yeah, the concept that anyone really has full control over the weight is, I'm starting to not really believe that so much anymore.
Yeah, there's a newfound empathy around this disease that so many of us clinicians are really learning and trying to extend to our patients because you and I both see women every day who I have complete confidence they're doing everything they can to try to be healthier, and they really struggle.
Yeah.
So I guess I'd ask that you speak a little bit about those kind of factors that impact body weight, genetics, diet, level of activity. Can you address genetics, for example?
So genetics, there are certain disease processes or genetic diseases or disorders that actually lead to obesity at a very young age. And then there is a whole complexity of genetics that people are starting to think that roughly about 70% of obesity is probably related to genetics, and maybe 30% is related to other things. Um, but yeah, I think we're just scratching the surface on that genetic component. And then you start to look at the bacteria in our colons, right? And how that impacts our satiety and our hunger and our stress levels and our depression. And people who live together in the same home have a very similar microbiome in their colons. Is that a genetic part of it, or is it an environmental part of it? It starts to get a little bit muddy there. But I do think genetics are a big piece of what we're seeing.
Yeah, nature and nurture. It's not uncommon that I'll meet three generations of women from the same family, excuse me, and each one comes in with a level of obesity that is just reproduced generation after generation. And sometimes I think, is it a matter of what's in their kitchen cabinets and that there is no opportunity to eat healthier? Or is it just that there's some genetic proclivity that just perpetuates this generation after
Yeah.
generation?
And I think like the concept that the way your body responds to certain chemicals in foods you're eating, genetically speaking, may be more powerful for some people. If you take it back to that thermostat effect, is there something in the way your body, how your body responds to those chemicals that is throwing that thermostat off more intensely than someone else who doesn't, who's not genetically predisposed?
Yeah. We could have a whole podcast on the microbiome, and I think it's actually a really good idea that we do so because so many folks underestimate the impact of the bacterial flora in their whole body. And I, again, as a gynecologist, I'm constantly telling women, stop scrubbing because they're eradicating the microbiome of their vulva and vagina, and hence coming in with actually imbalances constantly using soaps and body washes. And there's something analogous in what people are eating and how they're impacting their microbiome, not only with foods, but the impact of antibiotics and lifestyle.
Totally.
Yeah, yeah. So, what do you think is the number one reason we're in this pandemic of obesity in this country? What's going on?
I think it's pretty hard to nail down. I mean, I think that we can definitely pin some of it probably on the types of foods that we're enticed to eat.
Relishing and wanting when we go to the bakery next door. Yes.
Yeah, it's interesting because I do bariatric surgery, like you're saying. And if you go to a patient's room post-operatively and you look at the TV and just like a regular channel, like every other commercial is somehow related to food. And it really is wired into our lifestyles, like commercially driven, that we're looking for some kind of pleasure or enjoyment based on food, right? So I do think that's a big factor. And processed foods, again, going back to that microbiome, right? Feeding bad bacteria constantly, and these bad bacteria are overgrowing and they're producing things that it's affecting our immune systems and our ability to feel full and ability to, again, going back to that thermostat, like regulate that thermostat.
Say no thank you to the third serving. Yeah. There's so many factors that impact this. And again, as you've pointed out, there's so much study that still remains to better understand the propensity for obesity. So I'm curious about some of the social issues too. Have you observed that socially advantaged women experience more dissatisfaction with their appearance and body weight than their disadvantaged counterparts?
I guess I've never thought about it completely. I guess I haven't not observed it per se, but I haven't necessarily keyed into that thought process.
What about racial differences around obesity and body types?
I think there's definitely not necessarily race, but socioeconomic factors at play with the types of foods you can afford and the types of foods that you're introduced to based on what you could afford. I think that definitely factors in a lot of the time. I don't know that race per se is a factor as far as what the patients I'm caring for, but definitely I think there's a socioeconomic factor at play.
Yeah. So much of what we are doing or trying to do is help patients focus on health and wellness and a sense of feeling good. How do we help women move away from looking at the scale per se and focusing on just overall health?
From an obesity perspective, or just in
I
general?
guess whatever perspective you want to talk about, really.
Yeah, I think that, again, going back to originally what I was saying, people want to feel good about their life and how their energy levels, what they're doing, how they're doing it. They don't want to be in pain. They don't want to feel fatigued and tired. They want to do the things they want to do and enjoy them. I think from a perspective of obesity, there are things that we can do medically to help. And then I think what you're saying is that people have to feel comfortable to a certain extent about who they are and their body, their weight. Those are important factors. But it's a complex. There's a lot of complexity to that. Talking to my patients, you start to understand the whole emotional and psychological component of weight and how it affects people. It goes pretty deep, and there's a lot to it. It's not something that's easy to solve or easy to figure out.
Yeah. In contrast, I will sometimes have a woman who's full-bodied come into the office, and I say something about, I think it would be healthier for you to lose some weight. And that woman might say to me, I am really fine. I am cool with my body size and shape, and that I have no interest in losing weight. And so then I have to applaud them for loving their body, but I also have to say, hey, listen, I need to talk to you about the risk of heart disease, stroke, cancers, diabetes, because these diseases we have very firmly, identified as risks when one is overweight.
Definitely.
Some of it's about age too, that when women are young, they often don't think about themselves at risk for these diseases. And of course, I speak to so many women going through the perimenopause and menopause, and we all talk about the mid-weight that happens during that time. And then all of a sudden there's this recognition. Oh yeah, I'm not just talking about how I look, but how I feel and how I move through my day, but also all those risks.
Yeah, totally.
Yeah. So in your office, do you have someone who's talking to someone about their emotional and psychological well-being as well?
We are trying to hire that person.
Excellent.
But we do have support groups. So that's a big part of what we do. We offer free support groups to the community. based around not only bariatric surgery, but obesity and the emotional components that go into that. And then, lifestyle as well. We've identified a couple of programs, one great one up in Albany, I believe it's called Live Well, that they do a lot of start to finish counseling in terms of weight and behavioral modification and eating disorders. So they have the full spectrum. So it's nice to have that. So we refer a lot of patients
Great.
up to them, and they take a lot of insurances, which is great.
So there's a lot of conversation right now about medicines to help lose weight. Ozempic is anywhere and everywhere you read.
Yeah.
How would you guide patients around medical therapies versus surgery? How do you begin that conversation?
Um, so from my perspective, I want to be able to offer the medications as much as the surgery or more than the surgery. I think that a lot of times patients don't get referred to my office from other providers until their BMIs are 55 or 60. And really, I think the process needs to start a lot earlier. I think that being when someone's body mass index starts to get into the 30s is important. So there's a fear certainly around surgery. No one wants to have surgery to help them lose weight, not what people are seeking. But I do think the ability to provide medications and intervene at an early place is important as these medications grow and develop. So there are a lot of classes of medications and different types of medications, starting with phentermine, which is like a holdover from fen-phen, right? It's essentially a medical grade speed for the most part as an appetite suppressant. Unfortunately, it's also cheap, and that's usually the one that the insurance companies will approve the most of. And then going all the way up to Ozempic, which could be quite expensive if your insurance company is not going to pay for it. So those medications that are injectables like Ozempic, also great medications. If you think about that thermostat concept, they're hormonal therapy. So they're targeting one of the hormones we believe that will help to lower that thermostat. Surgically, we're changing a lot of those hormones that target the thermostat. That's why the surgery statistically usually win out over the medications and the diet and exercise alone. It's because we're actually turning that thermostat down. It's not just, hey, eat less and work out more. It really doesn't really have as much of an impact as we think.
Yeah, and sometimes it sounds patronizing too, because we can say that until we're blue in the face. And if people are struggling with their thermoregulatory system or their microbiome and all of these factors that contribute to obesity, it's not really helping them.
Yeah.
So how often is surgery successful? How often does what you do in fact change people's course?
Well, I would say a lot. I know,
Great.
It's one of the reasons why I went into that specialty, right? One reason is the gratification that patients have when they lose that weight and they feel better and that their lives are changed. And another is that I get to follow up with them for their lifetime. So we try to make it a lifetime approach to our program. So you do see patients regain over time, not all patients, but there are patients who start to regain over time. And I think that's where the medications are also very helpful. Coming back to see us and emphasizing that lifetime follow-up thing is important. The hard part is understanding why the thermostat starts to go back up again. Is it purely a genetic thing and we're just fighting this thing that we'll never be able to overcome? Or is it, again, certain chemicals and certain foods? Is it psychological in terms of stress and how you react to stress and how you behave around a stressful event and turn to maybe bad habits that are undermining your success? So there's a lot that goes into it. Certainly, we haven't gotten to the point where we can keep patients' weight off indefinitely if we're not accounting for all these factors.
Yeah. So I'd be remiss not to talk about diet. Again, I'm asked all day long, every day, oh, what diet should I go on? And I think I give women a really unsatisfactory answer. I say, you know what? There's no one diet that works for everyone, and you have to explore what foods feel right for you. And there are certain basic guidelines around fats and proteins and sugars. But what would you say to women around? I mean, there are probably hundreds of diets out there on the internet. How do you address that with your patients?
Yeah, it's tough. Like you said, there's so many, right? I'm probably somewhere like you where I don't necessarily say that there's one thing for everyone. We try to break free from cycles of dieting, right? A lot of people get into that cycle where they diet, they lose, they come in and they say, well, 30, I was able to lose 50 pounds. And slowly it came back over time. And now I'm 45 and I can't lose that 50 pounds anymore. It's so much harder to do that. So, from my perspective, it's break free from that cycle of dieting, go more towards choices, food choices. We promote more of a whole foods type of diet, fiber focused, healthy proteins, that kind of thing. And then combine that with lifestyle type of thing. So slowing down the process of eating, I'm guilty of it. I eat way too fast. And a
All
lot of
doctors
us,
do.
yeah, but I think people do.
Yeah.
And I think putting the fork down in between bites, making the bite size a little smaller, just gives your brain a little bit more time to catch up with your stomach, right? There's that delayed effect. We try to stay away from getting people into the mindset of dieting and just get them onto the mindset that, like, okay, I'm going to make healthier choices and try to change the way I approach my meals and eat meals.
Yeah. And to include exercise and other ways in which to have a sense of well-being.
Yeah.
Certainly. Yeah. And I spend time in my office often saying to women, I see so much ill health that I also want to remind you that extra bit of roll and love handles that you might have now that you're 55 is healthy from the perspective that you don't have cancer, you don't have heart disease, and that the extra 5 or 10 pounds that you're carrying, it is perhaps important for you to have. So again, reframing the way we look at body types and how we feel about our own bodies and those of our patients.
Yeah. And I
Yeah.
think you bring up a good point because it matters where you hold that fatty tissue, right? If you're holding it around your organs, that's very bad. And that's the stuff on the inside you don't see. But there are people who are very healthy who do have extra adipose tissue or fatty tissue that it's fine. It's not going to cause disease. It just is what it is.
Right, right. Brian, I can't thank you enough for being here today. This is a huge topic, and we might need to regather again to go into other realms of this issue. Thank you also to my listeners for joining me as we venture into the limitless conversations about our bodies and the world of OBGYN. I would love to hear from you. Please email your questions and comments to comments@radiofreerhinecliff.org or call us at 845-307-7446. Also, thank you to my producers, Jen Hammoud and Matty Rosenberg. Until our next conversation, stay healthy and stand strong in your knowledge and your insights.